It is with great pleasure that I get to introduce our next presenter, someone who you may not have met before, but possibly you have, our conference host, Cathie Sherrington. Cathie is a professorial research fellow at the George Institute for Global Health and the Sydney Medical School, the University of Sydney. She leads the Ageing Research Group within the Institute's Musculoskeletal Division. Prior to completing a Masters of Public Health and PhD, Cathie was a clinical physiotherapist in aged care and rehabilitation. So welcome, Cathie.
Thank you, Terry. And I'll just point out that the choice of speakers was actually done by secret ballot by the Society executive, so the hosts didn't actually invite themselves. I'm going to find the pointer. So I'm going to be talking about preventing falls in high-risk groups. So I'm going to focus on looking at what we know about the effectiveness of fall prevention interventions in community-dwelling older people who are at a high risk of falls. So who are these high-risk community dwellers? So we know that older people with poorer function than their peers are at an increased risk of falls, and so this includes strength, balance and vision. But we also know that there's people with certain conditions and in certain situations that seem to further increase the risk of falls. So, for example, stroke, Parkinson's disease, dementia, frailty, and it seems recent hospitalisation and emergency department presentation. And so I think we don't really understand yet whether these really are distinct groups or whether they're on a continuum. Obviously, people with milder versions of the conditions may well be more similar to the general community, but it does seem that there's differences in responses to interventions. And this obviously has implications for intervention delivery in terms of working out, do we actually need different interventions in people with different conditions, and how can we best deliver interventions? So there seems to be a few options for delivering interventions for high-risk people. We could just include them in the rollout of general interventions, and we could have population-specific interventions. And so I've categorised these into terms which might not be ideal, but as a general intervention, so such as an intervention that is also delivered to the general population, but we might want to deliver it specifically for people from a particular population or with a particular condition. So I'd call those exercise and environmental or behavioural interventions. Or we might also want to use a dominant risk factor approach, which I'll talk about. It's also tempting to prioritise high-risk people when we're delivering falls prevention interventions. And so that's why we might want to use some sort of screening tool and then deliver interventions to those people who we find to be at increased risk. However, this actually assumes that we're confident that there is a greater impact of the intervention in these high-risk people. So we really need evidence of the effectiveness of the intervention in these people, not just evidence that they are at increased risk. It's also important to consider relative versus absolute effects. So in trials, we're actually looking at relative effects. So we talk about a 30% decrease in the rate of falls. So if you were to have a 30% decrease in the rate of falls in people who are actually at low risk compared to people who are at high risk, you're obviously going to prevent more falls in the high risk people, so more falls in terms of a greater absolute number of falls. However, you still need to be sure that you can get that 30% decrease in that higher risk population. And I guess I first started thinking about this when we had a surprising finding from our previous meta-analysis, which was that there was actually, of exercise as a single intervention, there was actually a smaller relative effect in high-risk people. So in the trials where people were at some sort of increased risk of falls, overall there was actually only a 10% reduction in the number of falls, whereas in the lower risk people or in interventions targeted at the general community, there was actually a 27% reduction. And this explained 15% of the overall variability in the impact of exercise on falls. But then to try and understand this further, I think we can look at the Cochrane Review. And this is obviously a fantastic resource, and we're very fortunate to have Leslie Gillespie and Claire Robertson here with us at this conference, even though they're allegedly retired now. And they've been the driving forces behind this review. So there is 159 trials in this review. It is the most commonly accessed Cochrane Review, which is fantastic. But sometimes it's hard for, to keep all the findings in your mind at the one time. So I've just sort of pulled out some of the findings with regards to risk status. So, in terms of general interventions, and so these are interventions which could be delivered to any population, from the Cochrane Review, we know that we can actually prevent falls in people who aren't screened for risk. So we actually can prevent falls if we just deliver interventions to the general community. So in terms of group exercise, home exercise, Tai Chi, and multifactorial interventions. Well, there are fewer trials on that, but one of them's very big. And so these, although we assume that we need to screen for risk and target high-risk people, there's actually lots of trials in the Cochrane Review which have just delivered programs to the general community. Home safety, interventions, it seems, don't work so well, certainly the way they've been done so far in trials in the general community. But then a number of the interventions have also been tested in high-risk people in previous trials, and then a technique of sort of subgroup analysis has been used to actually compare the impact. And so we know that multi-component group exercise actually does also prevent falls in high-risk people, and there actually isn't a significant difference between those effects. We don't yet know about the role of home exercise in high-risk people. It seems that Tai Chi, although there isn't many trials in high-risk people, it does appear to actually have a lesser relative effect in higher-risk people. Home safety interventions seem to work better in high-risk people, and multifactorial interventions also work in high-risk people with no difference between low-risk and high-risk people in the effectiveness. So then this approach of sort of what I'm calling dominant risk factor interventions. And so these are single interventions delivered to people who have a particular problem. And we've heard about a number of these. Actually, Jasmine mentioned a number of these this morning, which was great. So we do know that cataract removal, podiatry for foot pain, psychoactive medication reduction, which has also been mentioned, cardiac pacing and multifocal glasses, or for people who wear multifocal glasses, giving them single lens glasses works for preventing falls in people who go outside regularly. So then in the high-risk general community, we know that we can deliver single interventions, so group exercise and home safety. We know we can do a number of those dominant risk factor interventions, and we can also do multifactorial interventions. So in particular populations, though, there's less evidence, and it seems that home safety does work for visual impairment, cardiac pacing seems to work, as I said, and some of those multifactorial interventions have been delivered in higher risk groups. But what about exercise? So this is a really good example of applying a general intervention to people with a particular condition. So as we know, the Otago exercise program works extremely well in preventing falls in the general population, and even in people who are a bit older. I think one of the trials had an older inclusion criteria, but the people didn't have any particular risk factor to be included in the trial. However, it didn't appear to work in people with a severe visual impairment, although home safety did actually work in those people. So an exact program delivered by the same group actually didn't have the same impact in a particular population, those people with a marked visual impairment. And so over the last several years, we've sort of set out to document approaches to home exercise and also group exercise that were being used by a number of physiotherapists. So apologies for one of the photos there. And so we just documented the web program, or the weight-bearing exercise for better balance. But we haven't really invented it, and it's really just documenting what a number of physios are doing. And so it's looking at it's very similar to the Otago program, although it doesn't include any seated exercise. So we're focusing on the importance of task-related exercise, and really exercise then that we hoped would have a greater impact on functional abilities. So it involves different aspects of balance, so practicing reducing the base of support, so the feet closer together, controlled movements in standing, so practicing reaching, practicing stepping in different directions, stepping over obstacles, heel-toe walking, and also sit to stand and step-ups and heel raises, also resisted using weight belts if the person was able, or otherwise just with gravity, just resisted with gravity. And so this is a very sort of individualised approach where we've delivered it, the exact nature of it and the exact exercises are really tailored according to the individual's need. And so this was really developed to be able a way to sort of deliver home exercise deliver exercise to people at a high risk of falls. I'll acknowledge the Otago programs also involves a lot of tailoring as well. And so we've tested this in now 4 different studies in different types of people with particular conditions, and various different groups of investigators have been involved, but myself and Stephen Lord have been involved in all 4 trials. So first of all, looking at the impact on mobility of this approach, so led by Cath Dean, we found that a weekly circuit class using this general approach to exercise prescription did improve gait speed in actual chronic stroke survivors, so people that were quite some years after their stroke. With Nikki Fairhall's PhD and also Ian Cameron and Sue Curl led this study looking at frail older people. So we used this web intervention as a home exercise program delivered in 10 visits from a physiotherapist, but we also added other interventions targeting frailty. We also improved mobility with the faster gait speed. With Colleen Canning, who's here as well, looking at people with Parkinson's disease. And so she led the program, and also Natalie Allen, which looked at delivering this type of approach in a monthly group setting through Parkinson's New South Wales support groups, as well as home exercise for people with Parkinson's disease. We also improve mobility. So here the short physical performance battery summary performance score, which involves looking at gait speed, sit to stand and standing balance. And then the trial that I led, which was in people who'd been in hospital recently, again 10 physio visits over a 12-month period. So we were trying to get a program that was intense enough to have an impact, but low dose enough that it could actually be implemented. Again, we significantly improved mobility. As most of you have heard some of these results before, we didn't have that impact on falls. So in the stroke trial, a 4% reduction in falls, really no indication of an impact on falls. In the frailty trial, no indication of an impact on falls. In the Parkinson's trial, the news is a bit better. So there actually was nearly a 30% reduction in falls, but it wasn't statistically significant. But there was an interaction that there was a greater impact in the people with the lower disease severity. But unfortunately, we actually increased falls with this approach in people who'd been in hospital. And so that was a 40% increase in the rate of falls with this home exercise program. I should also note that people didn't actually fall while they were exercising. So why is this so? So why don't these mobility benefits actually lead to falls benefits in these people with particular conditions? I basically don't have the answer, but possibilities could be that mobility isn't actually the most important risk factor. Perhaps we're actually not improving mobility enough. We are improving mobility, but maybe it's sort of too little too late. Maybe we need a much bigger increase in mobility to actually impact on falls. Perhaps we're actually improving people's mobility and then they're actually doing more, so we're increasing the exposure to risk. Or perhaps these people are, at an increased risk and perhaps they need a greater focus on safety behaviour. So sort of having that additional mobility and then knowing how to use it carefully. So to look at whether, I'm going to focus now on the post-hospital study. So is mobility a risk factor in these people? Well, basically, yes, it is. So these are the risk factors in the control group over the 12-month period. And you can see the various mobility measures are all the most important risk factors. So these are all the, basically all the variables that we measured that were associated with the rate of falling with a p-value of less than 0.2, and the ones in bold are the ones where it was statistically significant. So you can see it is really similar risk factors to what we would expect in the general population with a lot of the same tools. So that doesn't seem to be the issue. I mean, obviously the post-hospital population is very diverse, so hopefully we can get some more information by doing some subgroup analysis. Now, this needs to be done really carefully in trials. There's a real risk of basically spurious findings and chance findings. I think the best way to understand this is a particular study that was published that actually found a greater impact of a certain medication in people of a certain star sign. So unless you really think that those issues hold weight, I'd say that really is a chance finding. So we need to interpret these very carefully, and we did have a few pre-planned analyses, but we've now done further exploratory analyses to really try and understand why we are actually increasing falls in this population. Not preventing them was one thing, but actually increasing them is more of a problem. There wasn't any differential impact on the basis of age, cognition, gender, falls history, medication use, comorbidity or physical activity. However, there was actually a differential impact on the basis of mobility, but in an unexpected direction. So we actually had a lesser increase in falls in people who had more impaired physical function. And gait speed was actually our pre-planned subgroup analysis, but it holds out in actually a number of different variables. So gait speed, the step test, the short physical performance battery, also strength, also fear of falling, and also the rehab people. So there wasn't an increase in falls in people who were recruited from rehab wards, because we recruited both from rehab and acute hospital wards. So that's a potential bit of good news. And this just shows that graphically. So on my left, your left too, I think, you can see that, they're actually, so the blue's the falls rate in the control and the red in the exercise. So the people who walked most slowly, there was no increase in falls in the intervention group. However, in the other groups, the people that walked more quickly, there was a difference between the intervention and control groups with regards to falls. And it seems that in the control group, people who walk more quickly actually fall less, but the exercise seems to have taken that away. So there's actually basically a sort of common level of falling in the exercise group across the different amounts of gait speed. And that same thing happens with the step test as well. So also the people in the lowest quartile of the step test, there's no difference between the groups. There's less of a difference in the second quartile, and in the third and fourth quartiles, there's more of a difference between the groups. So for some reason, it's actually the people who are walking, who are better, that we're increasing the falls in. As I mentioned, we improved mobility. So this is the lower extremity summary performance score at 3 months and at 12 months. So you can see there's a deterioration in the control group, but an improvement in the intervention group at 12 months. But interestingly, there's actually more of an increase in falls in those people who've improved their mobility. So the people who didn't improve their mobility really didn't get an increase in falls with the exercise, but the people who did improve their mobility did get an increase in falls with the exercise. Similarly with increasing physical activity. Physical activity itself didn't lead to a differential effect, but in the people who didn't increase their physical activity, there was no increase in falls with the exercise, but there actually was an increase in falls with the exercise in the people who increased their physical activity. And that's not quite, both of those interactions weren't quite statistically significant, but there does appear to be something happening looking at the graphs. So in conclusion from that study, that the increase in falls with exercise was greater in people who had better mobility at baseline. It was also greater in people who improved their mobility and also those who improved their physical activity during the 12-month intervention period. And so it seems to make sense that, that maybe we could help avert this by adding sort of behavioural and educational interventions to home exercise and investigating that. That's why I think Anne-Marie's got the answers, so I'm looking forward to her talk. Don't want to put too much pressure on you. And so what did other people find? Is it just us who have problems with people who've been in hospital? So Latham found no impact of a strength training program in people who'd been in hospital. And quite a few years ago, Morgan found no impact of low intensity group exercise in people who'd been in hospital. However, this is not a good graphic, but they actually also had a greater increase in falls in the higher functioning people. So the higher functioning people, there was actually more falls in the exercise group than in the control group. So maybe it's not just us. So in terms of overall conclusions then, we can say that both group exercise, home safety and multifactorial interventions can prevent falls in community dwelling people who are at an increased risk of falls, or I'd say at some increased risk of falls. So those people who are really people in the general community but who have poorer, who have falls risk factors compared to their peers. We can also prevent falls without doing screening by just delivering interventions, so both group and home exercise, and also multifactorial interventions to unscreened groups of people, so to the general population. But we need to remember that more falls will be prevented in high-risk people with interventions of the same relative effectiveness. So even though we actually might have a similar impact, say of group exercise in unscreened versus screened people, if we have limited resources, we actually may choose to do some screening to prioritise that. We know that single interventions targeting important risk factors can prevent falls. So I think we can use falls assessment tools definitely to predict who will fall, to help tailor interventions, but they really don't seem to be needed to work out who can benefit from both group exercise and multifactorial interventions, and that we really need a greater understanding of falls prevention strategies in these people with particular conditions. Thanks very much. I'd just like to acknowledge various people. Thank you. I'm not running.
I have to chase you down the stairs. Well done. Thank you very much.
Terry.